I'm going to talk about another type of energy, physical energy, that we are using very, very commonly in this type of pathologies. And let me introduce this technique of the high-intensity laser therapy in this scene. I put this in because that demanding young girl that you see in the escalator have had a degenerative and also self-limited and also non-inflammatory problem in the elbow that we but call epicondylitis, because the problem of this tennis elbow is something more degenerative than inflammatory, but this is a self-limited overuse disease. She has been seen by this doctor. This doctor has indicated not anti-inflammatory drugs, and afterwards physiotherapy. That is very common in the first stage of this pathology. As Dr. Teran told us, we have stages in the tendinopathy. But even though she has continued with the pain, and she asked the doctor what to do. And it's very common that doctors, especially young doctors, has in his head to go immediately to something to cut the pain, such as a corticoid injection. And we all know that that is not only a very limited good result, but also we know nowadays by different papers that the corticosteroids are toxic to the cells. So we can have a new pathology again, but worse because of this use. But when they fail with that, they are thinking in open surgery or arthroscopic surgery to release the tendon, in this case, the extensor tendon, to have less overuse. And they forget, at my point of view, that's why I'm telling this, my experience, I have 30 years doing this, that they forget that we have now regenerative medicine. And in regenerative medicine, we have steps that we have to go, such as in this escalator. And the first step that is tools that are physical stimuli to the cell that produce response and healing to this, in my experience, is one of the most effective in 99% of the cases, such as this or another cases that I will show, that prevent to go to the second step, that is semi-invasive regenerative medicine with infiltration, like PRP or another, that you can use it also. There are papers that demonstrate good result. And the last step can be the invasive regenerative medicine, in some cases, not in this tendinopathy of the elbow, but in others, you can use scaffolds or mesenchymal stem cells. So what I think that we have to go to the first step that I told you, because there are a lot of papers such as this, Silver, that demonstrate that physical waves like pressure, electric waves, photons, vibration, stimulate cell membrane, produce protein synthesis, cell mitosis, and also can alter the gene expression, changing the cell to produce the healing. In this presentation, I want to talk about photons. We are hearing in the other presentations about pressure. Now I'm going to talk about photons. That we all know that sun with heliotherapy has been a very good tool since the antiquity, and people use this, putting some wounds at the sun to have more effective healing. And after that, man has used this organizing better the photons in polarized light therapy, and nowadays with the laser therapy. Laser was described by Einstein in 1917, and Mester used this first in wounds in medicine in 1976. What is laser? Is a light amplification of stimuli emission of radiation. We use in the electromagnetic wave field the the waves that are in between 700 and 400 nanometers of length in between the waves that are the one we have in the color, in the visible colors. And also we can use infrared in some cases, such as I am using today. This is polarized and coherent photons pointed to a place. In 1960, the first surgery was done with the high-intensity laser therapy, that is a concentrated laser that can make fulguration and healing. And nowadays, the high-intensity laser therapy that is called type 4 is decollimated, opened, so we don't burn anything. We are following with this method to have better healing. And low energy fount of producer of the laser is only capable to go inside the skin. So in this type of laser, we only use in wounds or on superficial lesions. But when you have more power in your fount of production of the laser, you can go inside until including bone. That's why there are a lot of indications. Nowadays, I'm going to speak about upper extremity, but you can see here that a lot of indications for bursitis, synovitis, trigger points, epicondylopathy, even lumbar pain. Osteoarthritis is very important. I have a large experience doing this in osteoarthritis, degenerative osteoarthritis of the knee, that I will present in the next Congress in Spain, scars, wounds, etc. The literature in upper extremity, we have a lot of papers with good results, such as this, that laser therapy in frozen shoulder, epicondylitis also, as you see here, and also as you see in the other slide, in musculoskeletal disorders, and in subacromial impingement also. But I will stop in two papers that I feel that are very good because they demonstrate something that I'm seeing in the clinic every day. This first paper is about the gene expression of the chondrocyte that the laser can produce more stability in the chondrocytes when they're in the process of the aging. And also you can see that if you apply comparing in a control group laser in a cartilage, the extracellular matrix can produce more collagen 2, that is the most important collagen in the cartilage cell. So with that type of physics stimuli, you can have more stabilization and more extracellular matrix in the cartilage, that you can see that in clinic when you treat degenerative arthritis of any joint. And this paper is very, very important. This paper was done in mesenchymal stem cells in equine bone marrow derived mesenchymal stem cells, to demonstrate that this type of stimuli in the cell can produce a regulation of the cytokine expression in the inflammatory process in an injury tissue or an ill tissue. This paper make to me take to me to do in human something similar to see if that all that studies was true. And we, with a medical engineering that is now working, she's from Austria, now she's working in Chile, Dr. Cristina Ashok and me, decided to treat with this system stem cells in vitro in two experiments. The first one was to see if the cell, if you apply, comparing with a control group in these stem cells, laser, you can have more migration, also more proliferation. And in the last study we did was to demonstrate if was really this great capacity of this laser to produce anti-inflammatory effects. And first, what we do, we put these mesenchymal stem cells in flasks and put, as you see there, the energy. We use the same device that we use in clinic. We did a scratch with a pipette in the middle of the flasks where the cells were, and we measured this 24 hours later, and we could see that in the laser group, the scratch was completely closed, and in the other, continue open. So we see as you see in the graphic, that we have more migration. Afterwards, we put the cells in these well plates, 96 well plates, and we apply the fetal bovine serum, that is something to make the culture medium to proliferate. And what we saw at 24 hours is that in the control group, the proliferation was less than in the laser group. And the last experiment we did, that is the most important, is what we tried to see in cells treated with LPS. LPS is a lipopolysaccharide that is taken up from the membrane, the outside membrane of the gram-negative bacteria. And it's very, very irritative for the cells. And we put this irritative in some of our flasks and in the other not. And what we see in conclusion is that in the supernatant, when we apply this irritative in the cell, and we apply laser, we have the more, as you see in prostaglandin 2 and interleukin-6, the more elimination of these pro-inflammatory cytokines in vitro when we do this. And that can explain to me why, when we are trying some zones with a very big inflammation, if you apply laser, you can have a great response of anti-inflammation. In this slide, I say the same, so I'm going to be quicker. We have nowadays, and Dr. Moya is one of the most important people that can, with also people of India, that can done the first regenerative science journal. And I could explain this. If you are interested, you can go to the first number of this, and I explain the same and with more details of this type of research in this first number. Now I'm going to present a clinic study that we are doing in multicenter here in Chile in adhesive capsulitis. This is the experience of this doctor that is working with me in this type of pathology. In this study, he presented us in a webinar that have done some time ago. We studied 10 patients that with exclusion criteria, as you can see here, have adhesive capsulitis. We use this protocol, one protocol in analgesia and another in biostimulation, as you can see, 2 sessions a week. And we measure with the test of UCLA the rigidity and the function of the shoulder. And we can see that in 9 cases, we have good and regular results, excellent, none in nothing, but only 1 bad case. And the most important thing is that not only the movement and the function was improved, but also pain. Here in red is when they begin, and here in green, when they have finished this study, they have less pain. I want to show you some special cases that I have had in my life. This is one of them that is very interesting because it's not only a frozen shoulder, it's also a shoulder that have a partial tear that we wanted to solve because the pain of this patient was terrible. Here is the patient. You have here some partial tear in the rotator cuff. She have had some months before an accident. She was 65 years old, and she came to us with an adhesive capsulitis phase 2 with 10 of pain in the VAA scale. it was a terrible pain. We could even not move it. And we wanted to heal the tendon and also to try to treat the frozen shoulder. What we did, we put this patient in sedation, and in the moment of the sedation with the physiotherapist, we started to move this and obtain in the tendon remission of the partial cuff and the partial tear. We put shock waves in the common use that we do it for this type of patients of this type of tendinopathy with rupture. After that, and the following day that we know that the patient will have also stiff of the elbow, we continue with the protocol of laser and movement immediately. After some days, we start with the third phase of rehabilitation treatment, and you will see that this patient, after 1.5 months with that terrible pain and with completely stiff of the shoulder, we have not pain, only some pain in the movement, and we didn't use not analgesics, not corticosteroids, and this woman recovered completely. So this is a special case that we can use both technologies, laser and shock waves together. And the last case is a very interesting case. When you have a calcific tendinopathy, and you are, and this is a self-limited also pathology, and the pathology is starting to have the removing of the calcium by reabsorption, you never have to apply something that produce more irritation such as shock waves. You have to wait that and put some type of method that don't produce more pain and can help to the patient that this self-limited reabsorption would occur. What we did in this 53 years old woman that is a physiotherapist, and I will show you in the video, is in this case that she has a Gardner 3 calcification. It was starting the reabsorption. We decided not to use shock waves at all. It's not indicated, but we use, as you will see, high intensity laser therapy. Here we show you, here is the calcification grade 3. Here is the patient with a lot of problems with the movement. 5 sessions of high intensity laser therapy, and 6 weeks later, the pain was gone. QSLA has in the maximum, and you can see the woman moving the shoulder completely without pain. Here is the first, and here is the last, the post-treatment use of high intensity laser therapy. So in this, that is a very pro-inflammatory problem, you have to use something for the inflammation more than the reabsorption. So in conclusion, frozen shoulder and rotator cuff calcified tendinopathy type 3 are self-limited pathologies. Even so, frozen shoulder have a very slow improvement with manual therapy, and in significant number of cases, you need to use corticosteroids. I don't use it today, never. And in calcific tendinopathy, needle puncture also, like to clean the calcium from bursa, like the barbotage, when the reabsorption has departed because the pain of these patients are disabled. With high intensity laser therapy in my hands, both problems were solved by decreasing the rehabilitation in frozen shoulder without any type of anti-inflammatory drugs or corticosteroids, and also producing a rapid relief of pain in calcified bursitis in the absorption phase, avoiding any type of invasive procedure. As other presentators said, we are going to be very soon in Spain. I hope everybody of you can go to Madrid. I think it would be a very good Congress. You can see some presentation by Zoom, but other in presential. So I invite everybody to go there. Dr. Karin Freitas have done a lot of effort to do this, and we hope everybody will be in expectation of it. Thank you very much for hearing, and excuse me the long presentation.